Welcome everybody. Thank you for taking the time to invest in yourself for this Lunch and Learn today. Was just telling Marie earlier, for anybody that was on earlier, that we run a continual Lunch and Learn programme, and it's open to anybody in health and care, including members of the public. So anybody that's got an interest in improvement in health and care in our region, we're happy for them to sign up as members of Boost, which is our learning and improvement community. My name's Karen. I'm the head of learning and improvement for Boost, and I'm just Marie and I will just do a bit of a double act at the start, and then I'm going to hand over to Marie for her presentation today. There you go. That's just to let you know what the Lunch and Learns are all about. If you have an interest in delivering and presenting an improvement journey that you've had and wanting to share that out to the system, then get in touch. We're always interested in hearing from other people what stories they've got to share. So just some protocols. The main thing is just to invite everybody to switch their cameras off, which I think everybody has, and also just to pop yourself on mute. I think, Kelly, you're not on mute, but I might be able to mute you, so I'll give that a go. Yep, so I've managed to do that. We are recording today's session, which is the reason we ask you to turn your cameras off. So I'm going to hand over to Marie in a second. There will be a chance at the end of the presentation to ask questions when I'll invite you to turn your cameras back on, and then obviously we can interact. But if you keep your cameras off till then, that would be great. So Marie, hopefully that's a good enough intro into your session. I'll hand over to you.
Hello everybody, nice to meet you all, and thank you for giving me this opportunity to talk about me managing the Discharge and Patient Flow project here at Barnsley Hospital. Thank you. So I was tasked initially for this programme was to look at how we can improve patient length of stay. So after meeting with the chief operator or the project sponsor, we came up with a sort of a plan of how we can tackle the length of stay. So basically the aim of the programme was to get an understanding of what delays are caused in patient journey. So I wanted to understand that patient journey from coming through the front door in ED all the way to their discharge, and what processes do we need to put in place to support that early discharge planning. We wanted to look at ways to reduce unnecessary delays in that patient journey. So it was breaking it down into those little chunks, which it will become clear later on what them little chunks look like. And then all this that contribute to the patient average length of stay. So that was looking at ED length of stay and the length of stay when that patient is admitted to the ward. We also looked at how we could come along on our digital journey, so looking at all the paper processes and how they could be digitised. We're very big on supporting the adapt home first approach to all patients that are appropriate for that home first model. And then on top of all this ultimately had an improvement to patient experience and their outcomes. Ready for the next slide, please. So from my project management perspective, it was important that once I got all this information, that we got that project executive sign off. We got the steer from, I kind of put together a project board, and we got that sign off. We got the objectives in place, what we wanted to achieve from this programme, so everybody understood their roles and responsibilities. Next one, please. And then it was important that we identified those high-level benefits, what are we wanting to improve, get that baseline data to see any improvements that we do make does have an impact. So I use benefits, so like the high-level benefits was sort of like your length of stay, your ED performances, time of patients' discharges in the daytime, and sort of like how many patients we have with a certain length of stay. I also used the GERS and the health hospital, sorry, I've lost my words now, model hospital for their recommendations and benefits, as well as getting close with our informatics team for them to provide us data in trust. So my next step was went on to process map the patient journey. So I looked at the front door, ED, and then there were themes emerged from ED. So I get it that not all patients are the same. They could present with different issues. So I just based this on a normal medical patient going to the medical ward, so going to AMU and medical ward. As you can appreciate, this took me months and months to process map this patient journey as it was then. And this is sort of how we then developed those work streams, breaking that down. We had investigations, there was therapy work stream, we had a work stream for pharmacy. And then when we looked at all those issues and the data, we then was able to prioritise where we needed to focus on. So each work stream had their own dedicated objective. Are we all right to just move on, please? Thank you. And then what we also did is really important when we did do something right. We celebrated that success. We were very transparent in everything we do, shared patient stories, and we encouraged that learning throughout the trust. And we also as you can imagine, the work streams were kind of broke down into each journey. It was important that all those work streams worked together, and I encouraged that collaborative work, and it wasn't one person's problem and it wasn't one person's problem to solve. We did a lot of collaborative working to share, get that solution together, and we came out with a shared vision at the end of it as well. Next slide, please. So some of the issues that I found, and I say this, we uncovered a lot of issues, but I'm just going to give a list of some of them that we came across. So we did see that there was an increase of attendances and acuity of patients was high. A lot of patients didn't meet the criteria to admit, and I'll talk about that audit a bit later on. Uncovered that we have a high volume of rejected requests for radiology and blood samples. Then radiology patient, there was a lot of DNA from inpatient, and when we collected that audit, we kind of developed themes from that, and the top one was that the patient wasn't prepped at ward level. So that was that the patient didn't have the right cannula, they hadn't fasted. So we was able to escalate that, and the team then came up with a plan to mitigate that. So we also not meeting the national targets for time of discharges, so the 10% discharges by 10 and the 33% by midday. So we knew that we needed to look at how can we improve that time of discharges for our patient. We also realised that we had a bit of a lack of oversight of harm caused by delays. So we set up a deconditioning work stream that looked at kind of like detecting patients that potentially came to harm. And now they do monthly after action reviews, and we learn a lot from those as well. We also uncovered that when patients move ward, their medication wasn't transferred, so there was a lot of duplication in process, and not only that, but a cost associated to that. And there's a lengthy delays within pharmacy in dispensing medication. And actually, when you go and spend time with these teams, you kind of get a bit more of an understanding of the inefficiencies in the process, whether that's steps, paper, or just the process itself. And we also realised that the ward and board round was not consistent throughout the trust. So next slide, please. So our baseline data, the criteria to admit, we did an audit and we picked 5 very random days through a 5-month period. And when we sat with the medical lead for ED and looked at the patient, we actually discovered that 5% did not meet the medical criteria to be admitted, and a lot of them was for social reasons. So from that, we implemented an admission avoidance model, which I think I may talk about later. So when I was talking about the radiology slots, from a period within a year, there were 772 patients that ended up having to stay another day because they wasn't prepped the first time to have their radiology appointment. We had 2,005, and again, this is in a year period, 2,526 patients ended up staying another day in a hospital bed because there was no D2A or 1B slot for that patient. And 90% of our D1s, which is the discharge letter, actually started on the day of discharge, and we're trying to push that forward to actually they can be started on admission and work that up. And we did an audit on patients sat in an AMU bed who was moving to the bed base, and it took 4 hours for that bed to become available. So that was when that patient was ready to move, for the porter to transfer that patient, for domestic to clean the bed, for the bed to be made up, and for the next patient to be in. So 4 hours is quite a lot. And as I said earlier, that we know that we're not meeting that 10% discharge by 10 and 33% by midday. So the next slide, I'm a very visual person, and this is sort of kind of what we need for that patient journey to progress quite quickly, well, in a timely manner. And the kind of work stream down the left is the work stream that we pulled together to make these improvements. And as you can see, there's some investigations, it happens quite a few in the patient journey, but it's making sure that when they're in ED, that everything's appropriate and right for that patient at the right time, and making sure that patients do meet the criteria to admit. So what we do now is when the doctor made that decision to admit that patient, it's all electronic. It will flash up, does this patient meet the criteria to admit? And we capture those that don't, what's the reason why. So we've identified gaps, hence why we, the top one historically was social patients. When it's out of hours, they was admitted because they couldn't be safely discharged home. So now they get admitted to CDU if it's overnight, and our Home First team member will go and assess that patient and get them straight back out into community. So it streamlines that process, and it works very well because they work with the social worker. So if there is anything related to social reasons that are known, the process is done quicker. I'm ready for the next slide, please. And then this is, again, it's just another visual representation, how patient flow, how that can be improved with all these little processes. And, you know, we ultimately here to reduce patient harm, and reducing length of stay will prevent deconditioning, which we are doing a lot of work around deconditioning, getting patient active, getting them out of bed when it's safe to do so, and getting them ready towards that discharge. And it's important that you've got that data as well, and you've got not working in silo, encourage that integration with who you need to integrate with for the patient. Next slide, please. So obviously I've just talked a little bit about the criteria to admit audit, but it is important that you have a multidisciplinary team doing that audit. So the audit that we use, it recommended from ESIST, and it is really useful in identifying any other gaps. So other gaps that we discovered through that audit was patients that from SDEC. Could patient have come back the following day to SDEC, and some pathways that not supported out of hours, and just putting some sort of a safety net. So these are the other services and pathways that are being looked at from just doing the criteria to admit audit. So when we said that 5% of patients that was admitted, that was, so you were looking about sort of 5 patients a day that was admitted for no reason. Implementing the model that we implemented, we cut that down to 2 patients a day, so we kind of reduced that by half. So the criteria to reside, we look at patients that don't meet the criteria to reside when they're in the hospital bed, and we derived common themes from that. So it was patients that are waiting medical review, patients that are waiting for radiology, and actually when we uncovered that, reason for radiology was that actually patient had the radiology appointment, or they have got the appointment coming up that day, but they weren't keeping track of when that radiology appointment was, and the results was already there. But so it was kind of like, right, they need to be prompted. So we're working to a process on how we can get that communication better to the doctors to sort of act on that quicker. So ED, so we got, I don't know if anybody's familiar or have a service like this, but here in Barnsley, we've got a service called Right Care Barnsley, and it's a single point of access for our patients, and they can, part of the admission avoidance, they can do a lot of support with our patients for this. But we realise that a lot of this it does need to happen at the front door. And when we interviewed our colleagues in ED, there was a lot of gaps in their knowledge of what Right Care Barnsley can offer. They didn't know how to refer patients. So historically, these would have been your social patients, and anybody that's known to Right Care Barnsley that could have been streamlined into community like IV antibiotics. So now we're working with the team to bridge that gap in knowledge. So, oh, sorry. And then just that last one, it was just about that AMU bed availability, what I was talking about earlier when we did that audit. There's also a bit of a communication issue around delays, porters knowing when that patient's ready to move, and domestic coming and cleaning that. It's all verbal, and we are looking to implement a patient tracking system which will automatically alert porters and domestic that the patient is ready and the bed is ready. So that 4 hours that I said that it takes for a patient to fill that bed, we're hoping to improve that by at least half, so it's 2.5 hours for that patient to be ready to transfer, and then the bed becoming filled with the next patient from ED. Next slide, please. So I probably have been talking about this as I'm going along, so I apologise. So some of the successes that we've done, we did do a site review supported by ESIS, and we acted upon their recommendations that we needed to implement a matrix OPAL scoring, because when we looked at the OPAL scoring, it was kind of historically what the people's interpretations was. So having this matrix, it automatically works out by a set criteria, and we've implemented action cards based on what OPAL scoring the trust is at. And then they was looking at doing a bit of a reset day as well, and how they can improve flow. We did have done a restructure of the phlebotomy team, because a lot of our delays was waiting for our patient to have their blood test done as an inpatient. So if the request had been done after sort of dinner time, that wasn't being picked up until the following day, because how it used to work is the phlebotomy team used to go down on all the wards in first thing in the morning, and then if they'd been up at 8 o'clock on the first ward and the doctor had gone and reviewed that patient and said, oh, we want blood, then they wouldn't be going back. So we found a massive delay there. So that we can just actually say that now there's a better system in place for those discharge blood to be prioritised and to be done timely. We found that early on in the journey, before we became a bit more advanced on the digital side, a lot of papers were being scanned in incorrectly. People were complaining that they couldn't see patient previous care because of the quality of the scanning. So we developed a stop, how that document should be scanned. We also supported with the transferred medication stop, so that's making sure that medication kept with patients and that it's stored correctly at ward level as well. And therapist services, we found that therapist referrals was all done by telephone, which was documented on a piece of paper, and they moved on towards digital referrals, and they wasn't seeing patients until patients were documented MedFit, but now they have changed and they will review patients before they documented MedFit, so it's getting that patient up mobile early on. We have been, we have sort of been testing the electronic criteria-led discharge performer in medical ward, and now we're moving on to the gynae ward. Historically, that was a paper, but now we've moved towards an electronic version. We've got the pro forma that both doctors and nurses need to complete, but we've also put a prompt into the daily ward round clerking form that prompts the doctors, does your patient meet the criteria-led discharge? And as I said earlier, we set up a work stream around deconditioning, so we're now more transparent around reporting of harm, and we're doing a massive campaign around eat, drink, dress and move, and collecting data around that, and just making sure that patients are being encouraged to eat, they are encouraged to drink, and we're working with our with the community as well. So we're trying to get the approach the same throughout the system. And then we've mandated the criteria to admit discharge. And we historically, when patients were ready to be transferred to the discharge unit, it was a telephone call. But now we developed an e-transfer form where the wards have to complete this form. It gets pinged to discharge unit, and then discharge unit will go and pick the patient up, and that's cut a lot of the time down in that patient journey. And I could go on, we have done lots of other things as well. But our next steps are we're rolling out the criteria-led discharge, and we'll be collecting the weekend discharge data because we want to see an improvement in that. It's going to be embedded that the monthly audit on criteria to admit and collecting that data around where patients haven't met the data to continue learning on those gaps in services. We're looking to develop the gold standard D1 process, so that's how can we get it completed timely, how can we get it of good quality, because sometimes it comes backwards and forward because it's not of good quality, there's something missing. Looking to develop a poster to inform staff around rejected investigations, so that's just reinforcing the information around what they're requesting for radiology and how do they need to get that patient ready for radiology. With that poster as well, we're looking at implementing a bit of a checklist on the electronic system when they do request that radiology. And then we're implementing the patient tracking system, which is coming soon. I'm working with the team to ensure that they do a structured board round, which I can say that now they do structured board round throughout the trust at 9:30. So it's getting processes in early on in the day. And as part of the deconditioning, we're looking at mandatory training to include that reconditioning to encourage staff to be thinking about deconditioning our patients, making sure that they keep them mobile when safe to do so. So what we've learned is it is important that you've got your right stakeholder and you engage early on, and working with them to understand what the delays are. It's understanding not just one point of view, it's understanding everybody's point of view. And we didn't want to, even though we managed the project, it was important that the workstream lead, they owned it. They were come up with the ideas of how they can improve for the patient, and encourage a lot of PDSA cycles, which was designed by the workstream. We're very QI focused here, and making sure that the service managers support the teams as well in implementing these changes. And as I said earlier, I don't believe in that silos working. I do believe in that collaborative approach. And to sustain this, I've done a lot of ward walk around to support any process change that we've done. I wouldn't call it handholding, I would just say is that support. You also get to learn a lot more engaging with your clinical staff as well that you've probably not considered before, and just making sure that you've got your SOPs and your user guide and any training. When you do a process change, get somebody who could champion that change on that ward, that landing, and making sure that you've got the resources electronically. So we have got an intranet page going through a refresh so people know that they can go to that place. And then whenever we've done a process change, so when we've done the criteria to admit, we've created screensavers, and that's been very useful from the feedback we've got. And keep collecting that data. If you see that improvement, shout about it. If you don't see that improvement, then that's when you kind of look at your PDSA and think, oh, what can we do next? So data collection is really important. It's important to be able to prioritise as well based on what your data is telling you. And thank you.
Great stuff. So thank you so much for that, Marie. Perfect timing. I'd invite people to pop their cameras back on, especially if you'd like to ask a question. So we've just got 5 minutes left for questions. Who'd like to ask Marie a question? Anything goes. You've stunned everybody into silence. I'll just give you a second to reflect to see if anybody would like to ask a question. Is there anything else you want to add, Marie, at the end?
Yeah, I think at the beginning, I felt very overwhelmed when I was tasked to sort of look at length of stay improving. But for me, yes, I have got clinical experience many years ago, but I wanted to get to, I didn't want to sit everybody in a room and process map. I wanted to actually be there. I've gone and shadowed patient, literally patient, and I found that very, very useful because when you are doing process maps and you ask people, talk about your process, what do you do? And then what do you do next? They don't tell you everything because it's like how do you drive to work? You do things that you just do and you forget. And there's a lot of things that I kind of unpicked by just getting that in that space, really. So I would recommend spend time with people, get to know you also get to know more issues as well.
Yeah, absolutely. And I think that building up a trust is really important, isn't it, for people to be honest about what they actually do, not what's on a standard operating procedure or what's written on the wall or what they're supposed to do. Is actually this is the way we do things around here, and that's what needs to potentially change. So
yes, and
really
that's
important.
what you need to that's what you need to capture. And when you do that as well, when you're spending time with your stakeholders, you are building them relationships up with them as well. And I've just found it very, very useful doing it that way. So that I would recommend in the first instance is not to get everybody in a room, to actually go and spend time with people, go and spend time with your stakeholders, and then you kind of encourage that sort of creative thinking and solutions.
Yeah, brilliant. Thank you so much, Marie.
No
so
problem.
I'm just going to do a quick plug of, before everybody goes, of our next Lunch and Learn, which I've popped into the chat there with the link, which is Workforce Development Approach to Positive Behavioural Support. So there's always such a wide repertoire of different Lunch and Learns that we do. So thank you, everybody, for coming today. Always get in touch with Boost if you'd like to either be connected to Marie or if you've got any other questions. Getting lots of thank yous there coming up in the chat. Thank you for that. Thank you for engaging, and we'll see you next time.
Thank you. Bye.